Tuesdays, here to answer any questions regarding blood flow restriction training. So I'll give everybody a minute or so to pop on, and so they can feel free to join in. You can send me a question via the chat. So I'm going to put in the chat, hello from Dallas. And if you have any questions, just pop them on in there, but we'll give everybody a minute because I am right on the hour here. All right, any questions this week? Okay, so what I wanted to talk a little bit about is my thought process as you're progressing people through BFR. And a common condition that I'm seeing right now is elbow pain. Either that's lateral epicondylitis or medial epicondylitis. And we all kind of have our favorite exercises, modalities to take you through kind of what I do. I really try to differentiate whether this is a true tendinopathy, tendinosis, or tendinitis. And if the how long it's been going on. Is it in an acute phase? Is it in a subacute phase? Is it in a chronic phase of inflammation? And most of my people want to play through these things. They don't want to take a bunch of time off, which would of course make my job easier because it's pretty easy to make people feel better when they're not being active on it. But when they're having this pinpoint pain right in the lateral epicondyle, and it's painful with resisted, like a resisted extension. I also like to test the fingers and see resistance in the extensors of the fingers. I do it straight armed, and then I do it bent armed to try to differentiate between muscles that are crossing the elbow versus muscles that are not crossing the elbow. Of course, when we bend a joint with muscles that are crossing it, we tend to put slack on that tissue, so there's not as much stress on it. We see that here at the elbow. We see it at the knee as well, differentiating between gastrocnemius and soleus. And so I try to get a good idea of what's happening. I also, because I am a manual therapist, I go in and I check the radial head, making sure that that is not misaligned. I will see that happen a lot. I will also see misalignment of the ulna as well. So ulna, radius, making sure that the joint is good. I like restrictive type bracing. And when I say restrictive, for the wrist, not allowing the wrist to break too much. Most of the time with my tennis folks, this is because they get this because they've changed rackets to a more firm tension. They've changed from a synthetic to a more natural catgut. there's a lot of variables that can come into play. Their coach changed their grip. So now that tissue is trying to accommodate to a changed grip. So many factors that you kind of have to weed through to make sure that we're addressing the underlying problem, because I can treat this thing all day long, but if they go out and they're playing 4 or 5 days a week and there's something wrong with their form, there's something wrong with the way that they're gripping their racket, there's something wrong with their racket themselves, then anything that I do in the clinic is going to probably be for naught. So getting with their coach and making it a team approach to me is very, very important with all these types of conditions. And I try to stay in my lane. I'm not a tennis expert. And I let the coaches take it from a grip and racket and those types of components. From an exercise standpoint, when we're talking about BFR, if it's a really acute early phase, high pain levels, I tend to let the tissue kind of calm down. I will use BFR to try to create a hypoxic environment for that tissue. Basically, if just even doing some extension is beyond a 2 out of 10 on a 10 scale painful, I'm not going to beat them up with that. What I'll do is I will just inflate the cuff at about 40 to 50% limb occlusion pressure, and I'll do what we call a cellular swelling protocol, which is 5 minutes on, 3 minutes off, meaning 5 minutes of pressure, 3 minutes of no pressure, 5 minutes of pressure, and giving them an opportunity. I'm going to type out the cellular swelling protocol. So 5 minutes on, 3 minutes off times 5 rounds at 40 to 50% LOP for upper extremity. So my goal with this is to create some hypoxia, to create some stem cell production, to create an environment for better healing. Now, I also use something called shock wave or sound wave. And what that does is it uses sound wave to cause little micro trauma to the tissue without damaging the tissue. And then using BFR on top of that, we try to improve, again, stem cell production, hypoxia, which should stimulate some nitric oxide and some other of the healing factors that will occur within the tissue. After the cellular swelling, maybe we do that for a week or so. Now they have pain-free range of motion where they can actually take the joint through some range, or it's just very barely uncomfortable. I will do an isometric. So isometricize using BFR, we do 3 times 1 to 2 minute rounds at 40 to 50% LOP. So I'm just going to hold a weight. I'm going to have the cuff on. I'm going to hold a weight. I'm going to hold it for a minute. Then I'm going to drop the weight for 30 seconds to a minute. And when they're ready, we'll bring it back up and we'll do it again. So we're going to do 3 rounds of 1 minute holds, up to 2 minute holds if the weight is too light. You can use a dumbbell. Sometimes I use even just like something super light, like I just have a can of Tough Skin here and they're just holding in order to get a little bit of resistance. In my mind, just kind of causing a little bit of tensile stress so the body can respond to that tensile stress. Maybe we do that for about a week. Their home exercises would be the exact same thing without BFR. They would just do isometric holds. The weight will have to be a little bit heavier, probably. Again, remember, we're using BFR because we can use very light loads, yet still get the same result as heavy intensity lifting or high intensity lifting. Okay, so after, so phase 1, a week or 2 might be cellular swelling, and a lot of manual therapy. Phase 2 might be isometrics. Home exercise, if isometrics are still too much, but cell swelling is too little, I might add a little bit of light stretching. At home, a lot of my patients have hypervolts and Theraguns. They can use those. So kind of however you kind of treat. Now we're getting into probably going to do from here, we're going to probably start doing some eccentric. So eccentric loading. And we'll be at 40 to 50% LOP. And we're going to use something like 20% of 1 rep max. Now, most of us in the rehab world, we have no idea what their 1 rep max is for something like this. So we're going to guess. We're going to use a light load, 2 pounds, 3 pounds. If pain elevates above a 2 out of 3 out of 10, it's too much. If they're not feeling anything in the tissue, then it's not enough. And so it can be, you know, it's an art. It's dosing it enough without aggravating it. No audio. Okay. Great, thanks, Sean. All right, so we are going to do 3 times 15 reps per day with the eccentric loading. So eccentric loading will look like, I've got my dumbbell. I'm starting with my wrist in an extended position. I'm grabbing the dumbbell. I'm slowly releasing. I'm taking the dumbbell out with the other hand. I'm bringing my arm up, slowly releasing. Okay, nice and slow, nice and controlled. 3 rounds of 15. Their home exercise is the same. When people are playing a lot and they're playing a lot of tennis or whatever is lifting weights or whatever is causing this elbow pain, sometimes I have to take that everyday protocol and I have to back off of it to every other day or every third day based on what that tendon is needing. And it seems like more so than not, my folks need to give it more rest than they're currently giving, is one of the reasons why this repetitive trauma has come up. So I got to mitigate through that based on what they can tolerate. Okay, so there is my eccentric loading. And then if that is too much, then what I might do is use just a rubber band around the fingers and just do open, close. So for every progression, I will have a little mini regression if I'm aggravating the tissue or if there's something that the patient can't tolerate. After we do eccentric loading, then I'm going to go to concentric loading. Again, concentric loading is going to be essentially the same as the eccentric loading, but instead of me just doing the negative component, I'm going to do the shortening component. Okay, so I'm just shortening the tissue. I'm using a load where I can barely feel it, but not so much that it aggravates. 2 ways that I know that it's too much load. Number 1 is the pain levels are above a 2 out of 10, or pain lasts more than about 20 or 30 minutes after the exercise is over. So if somebody's 2 or 3 or 4 hours after they're done with me, still having this achiness through the tissue, that means that I use too much load. Could mean that I use too much volume as well, but 3 times 15, probably not. Probably the load was too high. After that, I would do a combination of eccentric and concentric. So they'll just go through the normal range. So flexion through extension. And when I get to this point, I'm going to go to my typical, I'm going to go to my typical loading pattern with BFR. When we're doing strength, we're doing 30, 15, 15, 15 reps. So a total of 75 reps with a 30-second interset rest. Sean asks, is it true eccentric for one group is concentric for the opposite group? Is it true that eccentric for one group, one muscle group, is concentric? Technically, you are shortening if you're eccentrically loading, so you're shortening the antagonist. but not actively. So I think that it's more of a passive concentric. What I mean by that is if I'm slowly lowering, am I getting shortening of the flexor group? Sure, you are, but you're not actively contracting it. So I don't think that there's, it's a good question. I don't think it's you're actively contracting it. So it's not like you're actually doing concentric of the flexor group. The muscle is short, the group is shortening, but it's almost like a flaccid shortening. It's not contracting. You're mostly trying to resist that load and slowly lowering it, which we all are familiar with, that the Alfredson's work with the Achilles showing eccentric loading appears to be, beneficial for tendons and tenocytes to regenerate. That's why I tend to go to that tendon loading. And then after that, we pretty much want to go then to more sport specific and also some more intense, quick type responses, which you can get on the court. So more of like a return to play. Let's gradually get into hitting your normal amount, maybe playing every third day, then every second day, and then hopefully get them back to that 4 or 5 days a week, depending on what they're trying to do. And this would be the same thought process for me, whether it was a tendon of the elbow, a tendon of the knee, a tendon of the Achilles. I'm going to use kind of the same framework, but just in a different sense. If I can get to the point where I'm really, really heavy loading, like, one of the points about eccentric loading is that we can do much heavier eccentric loading than we can concentric. So take your bench press, for example. I load 225 or 2 plates on the bench press. I lock it out and I can slowly lower that much easier than I can rep it out, at least nowadays at 47. We want to heavy load that tissue. So that's where the eccentrics can come into play and be very beneficial because you're loading it more than what you could without damaging it. And of course, BFR contributes to that as well because you're loading it more than, you're loading it without damaging it. That's why I love the shockwave. You're stressing it without damaging it. All these things are trying to get the body to use their self-healing mechanisms so that it can do what you want it to do while you're bringing capacity up so people can tolerate and do the activities that they want to do, like tennis. And it doesn't have to be tennis. It can be, I see this with golf. I see it with weightlifters. I see it with CrossFitters. I see it with people that are gripping a lot. But it just has the name tennis elbow because it does happen there. What else? So hopefully you can take that thought process and apply it towards whatever tendon issue that you find. Do things change with muscles? Maybe a little bit. I might go into, instead of starting off with eccentrics, I might go right to concentrics, skip that, and then go into like some sort of plyometric after I feel confident that the tissue and the joint can handle it. It all depends. That's part of the art and science of the rehabilitation world. All right. Any questions for me? All right, awesome. Well, thanks so much for catching me at lunch. I will be back next Tuesday, and thanks for what you're doing, which is helping people and yourselves live healthier and happier lives. Thanks so much. See you next week.